Interventional radiology. I don't know. It's a specialty that we kind of all know about, but I think if you're like me, you don't really understand what interventional radiology is or what procedures PAs and NPs actually are able to do. So, if you are curious about this specialty, if you want to learn more about it, then please stay tuned because I am interviewing a PA who has worked in IR for over 20 years. Hi, it's Michelle with the Medicine Couch. Thank you so much for joining me. If you like this channel, if you think it's helpful, then please subscribe to the channel. Also, if you know colleagues that would benefit from it, please share my videos. Now, let's learn all about interventional radiology.
Ed Mathis. I'm a PA. I graduated from Hahnemann Medical College in 1981. Most of my career has been spent in institutional settings, 15 years surgery, 10 in internal medicine, and the last 21 years in interventional radiology at a university hospital.
Well, thank you so much, Ed, for joining us today.
My pleasure.
Can you just give us kind of an overview of interventional radiology as a specialty?
Sure. Interventional radiology uses imaging techniques, and that includes CT, ultrasound, fluoroscopy, MRI, to perform minimally invasive procedures for diagnosis and treatment. Interventional radiologists actually invented and perfected coronary artery stenting, angiography and stenting, most of the neurointerventional procedures that are done endovascular, most of the peripheral and central vascular work, stent placement, aortic stenting, etc. And then several cancer treatments are pretty much the exclusive realm of interventional radiology. In my 40 years as a PA, you can look at the progress from, say, doing an open abdominal aortic aneurysm that took hours with a high mortality rate to a 1 hour procedure with a little femoral artery puncture and deploying a stent with a low morbidity and mortality rate. So a lot of progress.
Yeah, I'm sure that's been pretty amazing to see things evolve through the years. So, work settings for interventional radiology, I'm assuming that it all happens in a hospital, or is there any other settings that interventional radiology works in?
I think anywhere where you find radiologists that have a fluoroscopy suite, you'll find an interventional radiologist. Within my system, the majority of the procedures are performed at our hospital-based clinic. But we also have a freestanding radiology center. Many of the outpatient centers are standalone centers. You may have a PA doing the procedures, but typically, depending on state law, an interventional radiologist should be readily available should there be an issue.
So, speaking of autonomy, how often does a PA work being the lead person in the procedure?
The role has evolved over the last 20 years I've been involved in interventional radiology. For the most part, the cases we do on our own without any physician involvement in the room. Prior to, I think, 3 years ago, there was no interventional radiology residency. It was a fellowship after a radiology residency. So we depended on the diagnostic radiology residents who may or may not have had an interest in interventional radiology to come over and do procedures. And if they weren't interested in doing procedures, we did most of them. If they were interested in doing procedures, then we acquiesced and they had first choice. About 3 years ago, interventional radiology split from a fellowship type training to a residency type training. So all of a sudden we went from having residents who really may not be interested in doing procedures to a cadre of residents that were doing procedures. So from that standpoint, the role of a PA or a nurse practitioner, because we do have both on staff, has shifted. There's a certain amount of clinic work and patient care work that needs to be done, consultations to be performed, pre-procedure evaluations, et cetera. And a lot of that has shifted and fallen to the PAs and the NPs on the interventional radiology service. So a lot of the procedures that I used to do fairly autonomously have been kind of parsed off to resident first.
And that's in a teaching institution. I mean, I assume there
Right.
are hospitals that don't really, get residents and stuff. So if somebody was really wanting to do those procedures, they would have more opportunity if they worked at a non-teaching hospital. Yeah.
Correct.
Okay, so since we're kind of talking about procedures, let's start with the more surprising procedures that IR, PAs, and NPs do.
CT guided lung biopsy, any CT guided procedure. I've done a lot of complex intra-abdominal procedures trying to get that retroperitoneal lymph node biopsy where it's buried in between, major blood vessels or nerve plexi. Some deep pelvic drainages, diverticular abscess or post-surgical low anterior resection, abscesses down in the pelvis. Some difficult mediastinal biopsy for folks with lymphoma or a big anterior mediastinal mass, and you have to rule out the 5 T's of anterior mediastinal mass. So those are probably the ones that are a little bit more surprising. Routinely, we do any tube changes or soft tissue biopsy using ultrasound guidance, thyroid biopsy, that kind of thing. That's all paracentesis, thoracentesis, central venous access. That's all pretty run of the mill for a PA and IR.
To reiterate, when you're talking about those more complex procedures, Ed
Yeah.
does have over 20 years, right, of experience in IR. I'm sure what procedures PAs and NPs are able to do in their facility has a lot to depend on their experience,
Right.
as well as the policies of the facility that they're in. So, are you going from procedure to procedure every day, or do you only do like a couple procedures a day and then you have all kinds of other work to do?
The system we have set up works for us. We work 4 10-hour shifts. We spend a day on the consult service. We spend a day on the clinic service. We each get a procedure day. And then that fourth day, it's fill in where needed. Prior to this system, every day was a procedure day.
Before the procedure, deciding exactly what they need or how it's going to be approached, is that done kind of usually in a team effort as well?
We do have a clinic, a pre-procedure clinic, where patients are referred for evaluation. Then they're seen in clinic, typically by one of the NPs or PAs and the attending on clinic duty that day. And a resident will join as they're available. And the patient is seen, of course, and worked up and tests ordered. The PA will typically follow up on that testing and report back to the attending, and then facilitate having the patient scheduled should they opt for the procedure. If it's a more minor procedure, they usually aren't seen prior. We go over outpatient requests for procedures, usually as a group. The attending and one of the PAs who's on the consult service will sit down and go through all those cases and decide, whether or not they can be done or should be done. And then they magically appear on somebody's schedule at a later date. And that's when we actually go in and introduce ourselves to the patient. Hi, I'm the guy that's going to stick you with a big needle.
Can you talk a little bit about the training that PAs and NPs typically get when they come into IR? Because it's not often something that we learn in school.
Yeah. We do take students a couple a year will have an interest in IR. And we do, one-on-one mentoring. It's a fully participatory rotation. For a new PA coming into IR, we prefer somebody with experience. We've found that new grads don't have that base in knowledge needed. I mean, certainly developing a manual skill is easy. I'm not going to say it's easy, but most anybody can do it. It's that general medical knowledge base that needs to be developed to help you recognize whether the procedure is indicated, what complications you may expect, how to manage any issues like their diabetes or their blood thinners that they're taking, etc. So it does take some experience, and our preference is to not hire a new grad. On the procedural side, you don't do any procedures independently until you're credentialed. And we do have criteria set up for each procedure that you may do that gets you to the credentialing point.
How do you train to do these procedures? Are there like mannequins or things that you can practice with, or is it just
Living, breathing,
learning on a patient? Yeah.
living, breathing humans. I prefer one-on-one mentoring in a room. You'll come in with me and watch how I do a procedure a few times. Then I may allow you to do certain components of the procedure, like isolating the internal jugular vein with ultrasound, giving the local anesthetic. Next step would be getting a needle into that external jugular vein and passing a wire. And then we progress as you go. I let you do more and more until eventually you get to a point where I'm going to stand there and watch you and coach you while you're doing it.
Some specialties are, very specific by the patient population that they see. But in interventional radiology, it sounds like you could have any patient, any age. Is that typical in like a large institution like you're in to see anywhere from newborns, on up all throughout the range?
At our institution, we have a pediatric interventionalist, and we actually have a peds nurse practitioner who covers that service for us. She does perform certain procedures, G tube changes, and that kind of thing. But again, it all depends on the limits imposed by your employer, the institution, and what you're comfortable with. But certainly, opportunity in birth through octogenarian or centrogenarian is there. And
Yeah.
most of our patients are elderly. I mean, I would say majority are well over the age of 60.
So, speaking of NPs, I know they can work in surgery. A lot of times, the institutions require them to go back and get a first assist kind of certification. Do you have any knowledge about if it's difficult for NPs to come in and do the procedures, or if they have to get any other training?
So one of the misconceptions amongst radiologists is nurse practitioners take care of patients and PAs do procedures. And that has been difficult to overcome for most of my career. Now that we've developed this residency or fellowship program, the duties are evenly split, and I think the interventional radiologists are finding that PAs are just as capable of taking care of patients as they are doing procedures, and same for the nurse practitioners. If you look nationally, and I'm one of the admins for the PAs and NPs and Interventional Radiology Facebook page. So if you look nationally, there's really no difference. And again, as you pointed out, it's institution preference. I can go 90 miles west and find nurse practitioners in the procedure room all day long. So there's that. And the Society of Interventional Radiology actually has a very active PANP section. At this point, I think it's still PA dominant, but as we see the increase in NPs, we're seeing that migrate into interventional radiology.
Talk about the specialty as far as things that you think either that you really love about the specialty or you think that most people would like about working in IR.
This is going to sound not great. There's minimal patient contact, if that makes sense to folks who work in a primary care office, and it's day in and day out talking to patients. Your contact with the patient is to introduce yourself, explain the procedure that they're going to have done, have them sign the consent. I typically talk to them throughout the procedure to get to know them a little bit better. And then when the procedure's done, you give them some discharge instructions and you send them out the door. They're not coming in looking for their narcotics prescriptions or an antibiotic for their viral infection or another counseling session on their inability to control their sugar. So, from that standpoint, coming out of internal medicine, it was a bit of a break. It's also an opportunity, I think, if you get in the right setting to pursue your own interests. Like my mother passed from lung cancer, so I've always had an interest in lung cancer, which kind of brought me to the lung biopsy side of interventional radiology. But on the side, I also participate in the lung cancer tumor board and a few other forums that deal with lung cancer within the institution. So that opportunity is there.
I love that. I always advocate for that when I talk to people. I try to see are there ability to make like niche practice within a specialty or whatever, because I really think that that's some of the key to people having longevity in their careers and fighting burnout is to identify what it is that they really love to do within the specialty that they're in, and try to do as much of that as possible. Speaking of downsides, every specialty has things that, are a downside to it, or things that people might not like about the specialty, or that they should at least be aware of if they are
Yeah.
looking at going into this specialty. What are some of those things that you think about IR?
Demand for the service is high. And like everywhere else, we're experiencing a workforce shortage. So the volumes are up, the hours can be long. Certainly putting in 12, 14-hour days is not unheard of. Choice of procedures that you can do. If you've outgrown your basic set of procedures and want to move into other areas, again, you don't get to dictate that career path. It depends on the institution that you're working for. And unless your physicians are willing to allow you to be challenged, then you can burn out relatively quickly and move on. Downside also would be minimal patient contact for some. You're not getting that follow up in clinic unless you're structured that way. If you're just a proceduralist, it can be very rewarding early on. But again, as you get further into your career, if you're just in doing procedures that other folks have picked and have deemed you capable of doing, that can get boring too.
What kind of personalities do you think do well in IR?
I think you need to be a little bit more aggressive. But at the same time, you have to be somewhat amicable. You need to be able to get along with people, but at the same time, advocate for yourself and for your patients. And you do need to have a certain sense of risk taking. If you're kind of a meek and mild person, you're not going to do well in IR. I think if you've got we'll call it a surgical personality. If you've got a surgical personality, they would do well in IR, as IR could be considered a minimally invasive surgical specialty.
How is charting in IR? Is it pretty templated and fairly easier, or is it more complicated than people
Yeah,
would think?
no, it's pretty templated. Even dictations. Society of Interventional Radiology does have a standard set of dictations that most institutions have adopted. Charting is minimal. Pre-op update, consent, pre and post orders, writing a brief procedure note for the chart, and then dictating that procedure note.
Can you give people an idea of salary in IR?
Yeah, it's probably, again, depending on your region.
Right,
I would say a new person with experience coming in making 110, 120,000, and that's salary, not
right,
total employment
with incentives. Yeah,
cost of
yeah.
employment. And there are a few places where you hear reports of folks making $200,000 a year. Personally, I think that's a lot of self-inflation of salary. I don't know anybody personally that makes that amount of money. So I would say probably an average would be 140, 150 for somebody
Okay.
with experience. Yeah.
In general, if somebody wants to come into IR, how would you advise them to kind of prepare? Any resources you could send them to?
Certainly having an RT license in certain states, like in New York, we can't apply ionizing radiation. We can't operate the fluoro equipment. So I've got three PAs who also are RTs, and that it doesn't apply to them. They can operate the equipment. I can go
And
across the
RT
border
is
into a radiologic technologist.
okay.
I can go across the border into Pennsylvania and step on the pedal all day
Yeah.
without any consequence from the state. In New York, you would lose your license if you're not an RT. So checking with your state laws to see what they allow. There is the American Registry of Radiologic Technologists, American Society of Radiologic Technologists, and the AAPA about 12, 14 years ago developed a guidelines curriculum for fluoroscopy for PAs. And that's a 40-hour online theory course and then 40 hours of practical experience at your location where you learn about radiation safety and how to operate the equipment. That's a good course to take. There are a couple basic interventional radiology texts that are available. One is Interventional Radiology Procedures, which essentially spells out how to do, step one, do this, step two, do that. And then there's the patient care in interventional radiology, which is a little bit more comprehensive that helps you get through, the steps of, how to do an IR consultation,
Yeah.
a brief description of what each of the procedures are and what to tell the patient and that kind of thing. There's a lot
Okay.
of online resources, especially through the Society of Interventional Radiology.
Okay. Yeah, I'll put links to all that down below in the description box so people can easily go to those different societies and find those texts. And I'll also put a link that Facebook group. Say the name of the Facebook group again.
It's interventional radiology, PAs and NPs.
Thank you so much, Ed, for shining some light on what happens in IR, and hopefully this helps some PAs and NPs trying to decide whether this specialty is right for them.
Thank you.
If you've watched this and you think, still not my specialty, still haven't found what I'm looking for, then click on this playlist here and it'll take you to a whole bunch of videos that are interviews with PAs and NPs working in all the various medical specialties. Thank you so much for joining me today. And as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.